Okay. So today's plan is, did you guys get the new PowerPoint I posted last night? Is that right? So my plan is today, chapter 15, 16, and that PowerPoint, new PowerPoint. So that is going to help for you guys for the pathophysiology and also for NCLEX. Okay. So let's talk about chapter 15. And pay attention during discussion also, folks. You guys okay over here? The microphone sound is okay at the back? Otherwise, I'm going to use this one. Is it okay now?
That works, yeah.
Good. Let's start. The first slide is over here. It says the components of the neuromuscular system, not neuromuscular junction. Neuromuscular system consists of neuromuscular unit containing the motor neuron, number one, myoneural junction, the muscle fibers, the spinal cord, and the descending pathways from the brainstem circuit. Those are the part of my neuromuscular system. Please know about what we have for neuromuscular junction. The important neuromuscular junction has presynaptic neuron, the synaptic cleft, and the postsynaptic neuron, which is also we call motor end plate. Presynaptic terminal, they release neurotransmitter, and the motor end plate has receptor for the neurotransmitters. It will coming up. So please pay attention. Now, classifications of muscles, we already discussed in anatomy. We have extensor group of muscles, we have flexor group of muscles. Flexor group of muscles, when it contract, it decrease the angle, cause flexion. When extensor group muscles at the back, this is my tricep right now, when it contract, it's called extension, increase the angle. That is extensors and flexor group of muscles. Now, mechanism controlling coordinated movement. These flexor group, extensor group, we call agonist, antagonist, we call synergistic. So please remember what is agonist. Agonist is which promote movement. Antagonist muscles are which oppose the movement. We have biceps over here. It is agonist. Tricep is my antagonist. Triceps at the back, which is antagonist. So when the biceps contract, cause flexion, this is agonist. Triceps relax, and when the tricep contract, we call extension. Okay. This is giving me, okay. Now we do have synergistic muscles, folks, remember. Synergistic assists the agonist muscles by stabilizing a joint or contributing additional forces to the movement. If you look at that synergistic, I'm going to give you an example. Again, we have biceps, we have brachialis, we have brachioradialis. Biceps is causing the flexion. Brachialis and brachioradialis, they are synergistically helping my biceps muscle for flexion. Main actor on the stage is bicep. Supporting actor or actress are brachioradialis and bicep brachii. Brachioradialis and brachialis. Those are synergistic muscles. Now, requirement of motor movement. Please remember, we do have upper motor neurons, which projects from where? from my motor cortex of the cerebrum, motor cortex, which is located in the frontal lobe, which we call the motor area, to the brainstem and spinal cord. Those are all descending tract. All descending tract are motor in function. Please remember. Now, how they're working? Directly or indirectly innervate the lower motor neuron or contracting muscles. The fiber which is coming from a motor cortex, which is part of upper motor neuron, and then from the ventral horn of the spinal cord, the fibers coming out through the ventral root of the spinal cord. Those are my lower motor neuron. Please highlight, remember, make it bold, it's called motor unit. What is motor unit? Motor unit is a motor neuron and all the muscle fibers it innervates. That is called motor unit. Make it bold. Now, we do have, for the motor system, we do have sensory feedback. Sensory feedback from the involved muscles. Who provide sensory information from the muscle? What we have in the skeletal muscle? Anybody?
Receptors.
What is the receptors in the skeletal muscles are called? What is the name of the sensory receptors in the skeletal muscles, which provide information to my brain?
The ganglia? The ganglia?
Ganglia. Anybody? No? At the Zoom?
Somebody posted something.
Pardon?
One. Just put, as you can put efferent.
From the skeletal muscles. These are called muscle spindle. Please remember. Muscle spindle, these are the sensory receptors for my skeletal muscle. Muscle spindle, these are sensory receptors in the skeletal muscle providing information about the length of increase the length of the muscle fiber to the central nervous system. Sensory. Okay, so that is taken care. The sensory, therefore, says the sensory feedback from the involved muscles continuously relate to the cerebellum, basal ganglia, and the sensory cortex.
Did you guys catch that? Professor, can you repeat that one more time? You said muscle spindle sensor receptors provided.
Yes, if you look at the sensory from the skeletal muscles, we have skeletal muscle fibers. Within those skeletal muscle fibers, we do have sensory receptors. And those sensory receptors are called muscle spindle. And muscle spindle is stimulated when I stretch, extension, whatever we do, or flexion. Muscle spindle receive the message, send message by means of sensory neuron to the spinal cord.
Thank you.
Now, those are going, not only going towards the parietal lobe, they're also going towards the cerebellum, basal ganglia, and that's what they already said, sensory cortex. Sensory cortex means they're talking about the parietal lobe. Is it clear? They're talking about the parietal lobe. They didn't mention the sensory cortex. Sensory cortex, that is my parietal lobe. Now, the functioning neuromuscular junctions that link nervous system activity with muscle contraction. Oh, again, so motor unit, please remember. Motor units consist of motor neurons and all the muscle fibers. All the muscle fibers it innervate, that is called the motor unit. Everybody okay with that one?
Yes.
Okay. Now we are now at the junction. A neuromuscular junction. It serves as a synapse between the motor neuron and my skeletal muscle fiber. the junction between the neuron and the skeletal muscle fibers, that is called neuromuscular junction. Neuromuscular junction, or we also call synapse. It consists of what? It consists of axon terminals of the motor neuron. We also call presynaptic terminal, and a specialized region of the muscle membrane that is called the motor end plate. Write it down, motor end plate. End plate, also called the motor end plate, which is a membrane which is located on the muscle cell. Plasma membrane of the muscle fiber, that region, that is called the motor end plate. What is the importance of motor end plate? Anybody? Why are we dealing with motor end plate? Why are we giving this special name? Anybody? I need something in the morning, not a coffee. Why they have special name? Please remember, folks, at the motor end plate, we do have receptors. All the receptors for the neurotransmitters are located at the motor end plate. Like acetylcholine is a neurotransmitter. So acetylcholine needs a place to sit, to come in contact, and that is my motor end plate. And on the motor end plate, we do have receptors for neurotransmitters. Okay, so now the next one. Everybody okay with following? Yes? Now the transmission of impulses, if you look at the transmission of impulses, is mediated by the release of neurotransmitters by the name called acetylcholine from my axon terminals. Axon terminal job is to release those neurotransmitters. It is the muscle cell at the motor end plate job is to receive those neurotransmitters, because at the motor end plate they have receptors. Now look at the last one. It says very clearly now. Acetylcholine, which is neurotransmitter, binds to the receptors at the motor end plate region of the muscle fibers to cause muscle contraction. End of the story. Is it clear? Yes? Anybody in confusion? So these are very, very important. Okay, now we have motor system, we have pyramidal, we have extrapyramidal. Pyramidal motor system, which originate pyramidal motor system, which originate in the motor cortex. What it does, it provides control of delicate muscle movement. All those voluntary movement are taking place with the help of my pyramidal motor system, voluntarily. Then we do have involuntary control with the help of extrapyramidal system. It originates mainly from the basal ganglia. These are the gray matter located within the white matter of the cerebrum, basal ganglia. What it does, it provides a background for more crude supportive movement pattern. It helps to control my body posture, my body balance. Those are extrapyramidal system. If something happens, it helps me to control the balance. That is extrapyramidal system. But I'm moving with the help of pyramid. And in order to control my body balance, the posture, equilibrium, those extrapyramidal systems have a role. Is it clear? Even I close my eye, I can touch, I can walk with the hand. These are part of my extrapyramidal system, providing to go along for maintaining balance. Okay. Question is, which motor system is responsible for crude, which we already said, extrapyramidal. Now, if you look at the extrapyramidal system again, we do have over there, we call the basal ganglia. Basal ganglia have different types of nucleus. They have the name we call putamen, globus pallidus, corpus striatum, and so forth. We are going to see in this slide. Like person who is suffering from Parkinson's disease. Those are the features of the Parkinson's disease, and that is where my basal ganglia is not functioning. Basal ganglia is supposed to produce some neurotransmitter, not acetylcholine, we call dopamine. Dopamine is not there, that's how my hands are started. My face becomes mask-like, expressionless, walking. Later on, it becomes so hard, bedridden. Okay. Now, movement planning. So please highlight all of them one at a time. Primary motor cortex. These are the areas which are located in the frontal lobe of the cerebrum. Frontal lobe, which is my motor area. Motor area is subtype or divided into primary motor cortex. What they're doing for? Responsible for execution of movement. I'm moving with the help of response from the primary motor cortex. Premotor cortex for generating a plan of movement. I'm going to go and planning, that is with the help of premotor cortex. And I act, I produce movement, I execute movement, that is my primary motor cortex. We do have supplemental motor cortex for rehearsing motor sequences of movement. Like anything, like a computer keyboard. If you look at computer keyboard, before I look at the number and punch. Now we are so trained, we don't look at the keyboard. Look at the guitar. Initially, we look at those strings. This is coming from the supplemental motor cortex. Tying shoelace at age 2 years. Before, mom used to see, go this way, go those further. What? Now, without looking at the shoelace, we can tie it. It's already trained. Okay. Now what happens from something going wrong? Disorders of motor function. We call the upper motor neuron lesion or the lower motor neuron lesions. By the way, did I record? Press the record? Yes?
Yes, Professor. Yes, you are.
Okay, thank you. So the upper motor neuron lesion can involve upper motor neuron can involve the motor cortex, highlight, not only motor cortex, they're coming through the internal capsule. This is a bundle of white matter, which we call internal capsule, and other brain structures through which, please highlight, there are two descending track, one we call corticospinal for both the limbs. My trunk is controlled by corticospinal, head and neck controlled by corticobulbar. Corticobulbar, neck and head. Corticospinal, upper extremity, my trunk, my lower extremity. Corticospinal. Okay. Now, if you look at the lower motor neuron lesion, Lower motor start from we have motor neuron which emerges, exit through the ventral root of the spinal cord. Then the motor fibers are going to the destination, that is my lower motor neuron. Lower motor neuron, they exit from the spinal cord. Upper motor neuron, they stay within the CNS. They never comes out. Upper motor neuron stays within the CNS. And CNS is what?
Central nervous system.
Brain and spinal cord. They never come out from the spinal cord. So the lower motor neuron, which comes out, disrupt communication between the muscle and all the neural input from the spinal cord reflexes, including my stretch reflex, which maintains the muscle tone, balance, and so forth. Please highlight both the terms: muscle atrophy, muscle dystrophy. Muscular atrophy is, if somebody asks, it is if a normally innervated muscle is not used for long period. What will happen? The muscle cell will shrink in diameter or decrease in diameter. Number two, lose much of its contractile protein and become weaker. That is my muscular atrophy. As somebody having a plaster cast, because of my fracture, they put a cast. After 6 weeks or 12 weeks, they remove it. Then I can see the note. I can notice that something is decreasing size of the plaster arm because I didn't use that arm for last 6 weeks. Atrophy. Then, by putting back to my exercise plan, we go back to normal size. Now, dystrophy is not, it is genetic. Please highlight, it is a genetic disorder that produces progressive deterioration of the skeletal muscles because of mix, highlight all the conditions. They produces muscular hypertrophy, muscular atrophy, and muscle necrosis. Muscle increase seems to be increase in size. And that increase in size, in the textbook, you guys can go ahead, look at that one later on, and because of the muscle fibers replaced by fatty tissue. That causes hypertrophy of the muscle. It looks like muscle has increased in size. Not because of the muscle fiber, it is because of my fat cells. Fat cells, connective tissues, others. And that is genetic. And with this one, muscular dystrophy, make a note, go over with Duchenne muscular dystrophy. It's a condition. Duchenne, D-U-C-H-E-N-N-E. Duchenne muscular dystrophy. Duchenne muscular dystrophy. Okay. Now move on to alteration of neuromuscular functions. Now, there are some drugs, some agents, some chemicals can alter neuromuscular function by what? By changing the release of neurotransmitter, number one. Number two, inactivating those neurotransmitters. Or number three, by binding with those receptors which are meant for neurotransmitter. My drugs go bind with the receptors and throw the neurotransmitter out from that position. So either they prevent the release, we use those drugs, and sometimes when the neurotransmitter release, we use drug to inactivate those neurotransmitter before it binds. Number 3, the drug can act on the receptors which are located on the motor end plate. The drugs are working in 3 different fashions: by preventing the release, by inactivating the drug, by sitting on the receptors. Now, highlight a drug we call Curare. Is it not highlighted? Highlighted. Curare is a drug or medication act on the post-junctional membrane. Post-junctional membrane, that is by muscle cell, plasma membrane of the muscle fiber, where we do have a receptor which we call motor end plate. What it does, this Curare prevent the depolarizing effect of acetylcholine. Very important drug. This is randomly used during surgery. And this drug, Curare, is controlled by the person who is giving anesthesia. Person who is giving anesthesia to the patient. Sometimes the surgeon said, I can't see, I can't relax, so I need some more relax. So anesthetic person, they increase the dosage of Curare to relax the operation site. If Curare is used as, make a note, used as muscle relaxant. Muscle relaxant. That's what it says, used during many types of surgical procedures. To relax the muscle, surgeon need help. So they ask anesthetist, can you increase the dose of Curare? But that has to be, they cannot give too much. Otherwise, if they give too much, then it cause problem for the anesthetist. So it will hard for them to revive the patient after anesthesia. Now please highlight Clostridium botulinum. It blocks acetylcholine and result in paralysis. Very randomly used nowadays as what? Anybody?
What's the question?
Question is Clostridium botulinum. They release a toxin, and that toxin, what it does, it blocks acetylcholine and result in muscle paralysis. We do use plastic surgery, Botox, muscle relaxer, to decrease or remove those facial lines, skin line, to get it more younger. Botox.
So that's what that is?
Botox is a chemical
Right.
coming derived from those Clostridium botulinum, and that injection is given every 3 to 6 months. Very expensive. To decrease those skin line. Okay, so that is Clostridium. Let me go ahead. Please highlight, it's important again, myasthenia gravis. Myasthenia gravis is a disorder of transmission at the neuromuscular junction. What it does, it affects the communication between the motor neuron and the innervated muscle fibers. Common cause of myasthenia gravis, it is autoimmune disease. Autoimmune. And those antibodies during autoimmune condition These antibodies sit on the receptors for acetylcholine. So acetylcholine doesn't have a place to sit. And that's why we do have myasthenia gravis. And please remember, myasthenia gravis, put a star mark on the slide. And that causes muscles of my face, muscles of my eyes, muscles, skeletal muscles. We feel difficulty swallowing, difficulty in walking. All those are affected by myasthenia gravis. And one of the renowned person, President Kennedy's wife, Jacqueline Kennedy. Like folks remember, I don't know history, if you go back. Jacqueline Kennedy was Kennedy's wife. After President Kennedy passed away, Jacqueline Kennedy married to one business magnate, merchant, ship merchant. His name was Aristotle Onassis. You can Google it. Aristotle Onassis, who suffered from myasthenia gravis. Like Lou Gehrig disease. Lou Gehrig was a renowned what? Baseball. Very good. Baseball. So he suffered from disease, ALS. Like right now I'm saying about Aristotle Onassis, he suffered from myasthenia gravis. Like become crippled.
Yes, I got a question.
Yeah.
You said this gravis affects the muscles, the eyes, skeletal, and what else?
Yeah.
You mentioned three. What was the third one?
Pardon, Tanya?
You mentioned three: the eyes, the skeletal, and what was the other one?
Face.
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 Good, thank you.
What was it?
Face.
Thank you.
Okay, so let's move. So myasthenia gravis. Yes.
You said there's like a loss of the antibody for the acetylcholine.
Yes. Acetylcholine is a neurotransmitter. Acetylcholine has its receptor site on the muscle fiber. That's what we said already. These antibodies during autoimmune disease, the immune system is supposed to protect. But now in autoimmune disease, they're producing antibodies, they are destroying my receptors. So where acetylcholine is going to go? Acetylcholine has no place to sit. Muscle relax. Even the acetylcholine is released, but they don't have any place to sit on those receptors. Receptors are already occupied and destroyed by those antibodies. Is it clear? Okay, that is myasthenia gravis. So please remember the story. It might help. I'm not sure. Okay. So next slide. Components of the peripheral nervous system. Peripheral nervous system, if you folks remember, PNS has what? What is the component of PNS? PNS, peripheral nervous system. If somebody asks me,
Spinal cord.
pardon?
Brain and spinal cord.
Brain and spinal cord is PNS. Brain and spinal cord is part of CNS only. Question is about the PNS, peripheral nervous system. Anybody?
Cranial and spinal nerves.
Pardon?
Cranial and spinal nerves.
How many are there?
12 cranial, 31 spinal.
Very good. Those are part of my peripheral nervous system. 12 pairs of cranial nerve, 31 pairs of spinal nerve. 31 pairs of spinal nerve. Then we do have other components. For the PNS, we have sympathetic and parasympathetic. Don't forget sympathetic and parasympathetic also. Okay. So, the components are sensory motor branches of the cranial nerve and the spinal nerve. That's what we dig. We know there are 12 pairs of cranial nerve, 31 pairs of spinal nerve. Of course, they have cranial sensory fibers, motor fibers. Number 2 is the peripheral part of my autonomic nervous system. That means they are talking about sympathetic and parasympathetic. Number 3 is peripheral ganglia. That means they are talking about the sympathetic chain ganglia. Sympathetic chain ganglia for the sympathetic, and for the parasympathetic we do have a ganglia either on the organ or on close to the organ, on the wall of the organ. Those are called terminal ganglia. So parasympathetic doesn't have a chain, parasympathetic has a terminal ganglia. Please remember. Terminal ganglia or sympathetic, why? The sympathetic has 2 chains because sympathetic chain ganglia. That's what they're talking about, peripheral ganglia. They didn't mention about that one, but I clear it. Now, the peripheral nerve regeneration. Before I go into this topic, peripheral nerve degeneration, the question is myelination. Who caused myelination in the PNS? Who caused myelination in the CNS? Everybody is okay with the myelination? Myelination is electric wire, all those are insulated. We call electric wires are insulated. We don't call for the brain cell, no insulation, we call myelination. My question is, what causes myelination in the CNS? What causes myelination in the PNS? Who is responsible?
Oligodendrocytes?
Pardon?
Is it the oligodendrocytes and Schwann cells?
Who is where?
I think oligodendrocytes are CNS and Schwann cells are the PNS.
Very good. Yeah, you got it. Schwann cell does myelination in the PNS. Oligodendrocyte or oligodendroglial cell does myelination in the CNS. Please remember, because we do those cells sometimes affected. Right now we are discussing the peripheral nervous system. That means we need to deal with the Schwann cell. Okay, good. Now, damage to the peripheral nerve axis due to injury or maybe due to any disease condition we call neuropathy. Result in degenerative changes followed by breakdown of the myelin sheath and also the Schwann cell. Schwanns are supposed to form myelination, and that myelination is gone. Schwann cell also itself is gone. Now the regeneration factors. Number 1, proximity to the soma. What is soma? What is soma? Come on, folks. What is soma?
Isn't it the cell body?
Yes, is cell body. Body, the word soma means the body. And over here, we are talking about this nerve cell, that means nerve cell body is soma. And we do have dendrites and we do have axons. Those are the processes. Dendrites are supposed to carry information toward the cell body. Axons are supposed to carry information away from the cell body. Now, proximity, if there is any nerve axon, if the axon is damaged close to the soma, no chances of regeneration. Is it clear? If the axons are damaged close to the cell body or soma, there is no chances of regeneration. Number two, if the injury, there are two types, is the crushing type and the cutting type. Clean cut, crush type. In crushing type, please remember this is the chances of regeneration. If you cutting type, no question. No regeneration with clean cut. Crushing, chances. Partial or complete. Yes? Everybody? Good. Okay. Again, this is very important. Called peripheral neuropathy. And the primary disorders, who is affected? It is my peripheral nerves. Might result, cause my muscle weakness, with or without atrophy, and might be some sensory changes. This peripheral neuropathy we divide into two broad groups. Mononeuropathy, only one peripheral nerve is involved. Polyneuropathy, multiple nerves are involved. That's what they call poly and mono. Mono when only one. Like my job is enter all those data on the computer. I'm using my hands, wrist joint. I'm putting pressure on my median nerve. Median nerve, which is going through the tunnel over my cathode bone, and we have retinoculum band. That band and the bone is pressing my median nerve. I'm suffering from carpal tunnel syndrome. This is number one. Now, we do suffer from a viral infection, and we call, and you take map out, my side of the nose, angle of the mouth, I'm drooling, this side become no crease. When I smile, I can express my right side, my left side is expressionless. We call facial palsy. 7th cranial nerve. Median nerve, 7th cranial nerve is cranial nerve. And the third one over here, the 5th cranial nerve. 5th cranial nerve is called what? What is the name of 5th cranial nerve? Trigeminal. And we do suffer from trigeminal neuralgia, severe aching pain in the temporomandibular joint. Trigeminal neuralgia, facial palsy, median nerve, these falls under mononeuropathy. There are others, but remember all this. Because I think they discuss in the book also. Okay. Mononeuropathies, right over here. Now, mononeuropathies caused by localized conditions, look at that one, such as trauma, maybe compression, maybe infection, that affect a single spinal nerve or plexus or the peripheral nerve trunk. Causes maybe the fractured bones, may lacerate or compress my nerve, or somebody is putting tourniquet too tightly, excessively tight tourniquet may injure the nerves directly or produce ischemic injury. That's very important. Now, number 3, last one over here. Please remember also, this is infection caused by virus we call herpes-zoster virus. Highlight herpes zoster virus. That causes what?
Chickenpox.
Due to chickenpox, and later on I had chickenpox at age 7, and right now I'm age 70, my immune system way down. Immune system way down, chickenpox virus remained dormant for last those 70 years, or 60 years. And now they get the upper hand because of my immune system is weak, because of my age. And they cause right now, they have severe painful rash, or they might affect the eye. That is called what?
Shingles.
Shingles, please remember. Shingles is also a type of mononeuropathy. Mononeuropathy. Shingles. Highlight herpes zoster and write it down, shingles. That may affect a single segmental afferent nerve. That's why they're so painful, because sensory nerves are involved. Painful rash. Now the polyneuropathy. What's the time? 10 o'clock. Polyneuropathy involves demyelination or axonal degeneration of multiple peripheral nerves. That's what they call poly. Poly, multiple peripheral nerves that lead to symmetric, both sides, right and left equal, symmetric sensory motor or mixed sensory motor deficit. There are a lot of conditions like those alcoholic neuropathy. We do have lead toxicity caused neuropathy, lead poisoning. We do have Guillain-Barré syndrome, Guillain-Barré disease, GB, Guillain-Barré. Make a note also for ALS, amyotrophic lateral sclerosis, ALS, and write down multiple sclerosis. These are all falls under what?
Polyneuropathy.
Polyneuropathy. If something comes up on the slide, I will mention. Okay. Now, typically, the longest axons are involved first. They're saying how it starts, with symptoms beginning in the distal part of the extremities. Later on, it ascends. Okay, yes, right over here. Okay. So, Guillain-Barré syndrome, it is one of the type of polyneuropathy. Arsenic, please remember, alcoholic, lead, metabolic, like diabetes mellitus, metabolic uremia, blood urea so high, and that giving rise to polyneuropathy. And also please remember the normal blood urea level, which is important. So somebody has type 2 diabetes, long history of diabetes, they might do suffer from polyneuropathy. we call diabetic neuropathy. Diabetic neuropathy, it is a type of polyneuropathy. Sometimes those patients with diabetic neuropathy, sometimes they hit the heart surface, they are unaware of the trauma. So it is very important, it's important for them to protect their toes when they walk. Otherwise, if the injury, infection, chances of healing is very seldom. Doesn't heal. Diabetic wound doesn't heal. Why? If it heals, takes a long time. What is the cause for delayed healing in diabetic wound? Anybody? What is the cause behind delayed healing of diabetic wound? Because of sugar. The tissue fluid at the trauma site are rich in sugar, and the bacteria love the sugar. Bacteria survive on those sugars. So it is very hard to get rid of those infections. So it is best to prevent than to have treatment. Okay. So lead toxicity would result in the following conditions. There's a polyneuropathy. Yeah. So lead, arsenic, alcoholic. I mentioned about the Guillain-Barré. I mentioned about ALS. I mentioned about multiple sclerosis. We see in this slide diabetic mellitus also. Diabetic mellitus is a very common disease. If somebody has diabetes mellitus start, is a lifelong commitment. Now, nerve root. Nerve root injuries. You guys need a break, restroom break?
Yes.
Okay, just go ahead and take a break. Take a break. I'm okay. Right now 10:10. Take a break. Returning time as 10:30. Folks at Zoom, we are taking a break. We return at 10:30. Stretch out outside. Relax.
Thank you.
Keep your parasympathetic system working. Yep. Okay. And you email me, please.
I will email you.
Pause of.
Excuse me, Professor? Professor?
Can you hear me now?
Yes. I came in late today. I just wanted to know, or I just wanted you to know that I'm present.
I saw you enter. I let you in, and I have so many students and so many things in my head. Okay. Hold on one second. Andrea, is that correct?
Yes, Andre Dragnacchio.
Okay, no problem. Thank you.
All right, thank you.
Like for the IPE,
Pardon?
IPE student, are you still giving that out?
IPE? You email me?
Okay.
Or you email me, right?
We email with, yeah, sure. She
If
put a
you
form.
let me, you are
Yeah, Kasuga, Lillian Kasuga.
Cressida?
Kasuga.
Yeah, I got you.
Oh, we do have a list.
Rosen Kosiva?
Yeah.
Dickinson, IEP meeting.
Oh, okay.
These are all highlighted.
Hey, Professor, this is Mecca King. Did you give me on attendance? I wasn't sure if you answered me or not.
He
Mecca,
said his list already.
uh,
His list already. He's.
you attendance and also you didn't appear your exam 3.
Yeah.
Email me the reason behind and take care of exam 3. I saw this, I checked this morning again, it was not taken care. Mecca, do you understand that one? Can you hear me, Mecca? Unmute, yeah.
I emailed you
So,
this morning.
exam 3, you didn't appear.
I emailed you this morning. I also sent you the screenshot of what I was occurring, what was occurring.
So please email me. Okay. You got it, Micah?
Yes. Can you hear me?
Okay, thank you. Okay.
the farm? Or for I finished halfway, but it's like really long. It's not sweet. Oh, one. The end?
To the end.
The end class?
To the end of the class.
I mean, like the end, like the end of the quarter. Do you have the answer? I have it down. I thought it was. Yeah, but it's not a bunch. I mean, good halfway. You did fine. Did you take a test? Did you? You finish it? Girl, mom. It's like the whole section. That's only week 5. Okay, it's week 10. Yeah, then week 10 this year. There's a week 3, there's a week 5 assignment, and then there's a week 10 assignment. That's why I don't think it's due on Wednesday.
There's 110.
No, like, you know how like you have different weeks of what is due? On the syllabus, there's week 3, AUTI, week 5, ACI, and week 10. Like, that's why I was thinking like, the ECM has to look.
Wait, so week 3 is,
Yeah.
is like the vital signs and function.
Yeah.
Uh-huh. And the critical thinking?
Critical thinking, like, oh, week 5.
Big 5.
Yeah, it's like a whole thing.
The student plan.
And then week 10 is something else. Yeah, week 10 is something else. Week 10 is a different subject, different section.
Each one.
That's why I was like, dude, I hope not.
And I
I know it's just the paperwork. Like, you know, a little package she gives us. Yeah, those are for sure due next lab.
water soluble or API. I have to do with energy. You need to do that. The first couple. Energy. But she's cool. She's like really on it.
Because I don't know if it's just it's just about functions, like the CD is about functions.
And then you're gonna know where you get your functions, food source, oversupplementation, with deficiency.
But she said not too much on the
No,
deficiencies.
oh, she said that?
Yeah, she said more on the functions. That's all of it. She gets all the vitamins.
I don't think she's good. I don't mean, you just don't know what she's not.
That's why I just feel like just keep going.
Because I'm doing, I've just been doing that and I'm just going to finish reading.
So like, as I read.
No, but then it just kind of, you hear it again.
Sorry, because I catch things that like.
Oh, you're like, oh, I write in my notes, like, question mark, and then
Me too.
Yeah.
Same.
If I see this I'm good. I can't imagine if I'm just,
Because water solubles not
What was our next question?
something I take you nutrients.
but we only took 4.
4 stuff. You already do. Only 4. 4 nights.
What's the final?
That's fine.
Are you taking one? Like we just taking this? Well, you're cheating. Oh, okay.
She's really good. Yeah, what's your breakdown? Like he talks too much, and then like you look like it's for me it's just too much talking. For her it's like this is a PowerPoint, this is a Gmail. That's what I know. But you should try it.
She's doing it tonight.
We do it like almost, yeah, she done it yesterday and then.
When she does that.
You have a ticket, so you get to take it.
But you have to join this.
Yes, too much, but this is good. No, you're not. Are you using the Patho? Are you doing a quiz like right after, like 3 hours? No, I think I feel better. Even but I was looking at the lecture. What I'm gonna do is just like every time I highlight something, I'm gonna highlight it on the study guide, so hopefully that works. Cause I lost from the last.
But the G.
I saw that. She had a
Well, I mean, last week's study.
Oh yeah, for sure. That's why I went to Dragon, but it was not that much. It's like some things we couldn't know already. But for neuro, did you say for email?
A couple days ago.
For what?
She sent us on the first quiz on the next.
Oh yeah, the little
Oh yeah.
before I knew.
I was like, I don't even know what I was like.
I was like, still trying to figure out how to tag that one. Wait, it's not that bad. I'll just keep it for later.
Oh, LEP. Did you get email for like submission of the learner? Did you? I never got one.
The one in your survey, the survey? You just get one. I'm not sure, but I'll ask.
You can do it. Okay. Did you get an email from what? For submission.
Oh.
I didn't get one, but. You only gave it to you. Oh,
dude, I'm not there.
That's what I was like, what you talking about?
No, she just has an overall because, I was like specifically, it's supposed to be 10 months. It wasn't be like, not, like, it's not like fine here, I don't know. Thank you. No, I said, I think it's people who have questions. Isn't that the lady who's our, who's writers?
What's her name, Jocelyn?
Oh, Joss, I thought this was an advisor. It's for marketing, it's for repeating.
It's been,
I think he's
Who's doing it?
let's do it. This one. This is the big check.
You don't have a single.
Nah, we can't.
Okay. Think about it now. I just have.
Another university like
Pictures of that.
Is it like that?
I just don't.
what do you like, pass out pizza?
5 weeks.
You
Is
do?
that what the hospital says?
Yeah, you guys have the Monday one?
No.
It's like 6:30, 8:30, and have to drive all the way back
He's
here.
supposed to go.
Yeah. I'm just gonna like wait till like the end of this
Yeah, Brianna.
I feel like the last year, the first year in nursing school.
Lean forward.
Maybe it's better if you do stuff. Yeah, they have something on the side that you do, you can pull out. So you don't just go.
And there.
What? Really? Because it's Saturday.
If you go on the weekend?
Yeah, you can.
For here?
I think so.
I did 4 hours.
What do you do?
That's on a Saturday.
Oh, this is the,
Yeah. Oh, it counts 4 hours. It counts as 8. Within their operating hours.
but it has
4 hours.
the volunteer hours are on. You can't like go up.
I don't know. I don't think so.
Okay, folks, let's get back.
When I asked her for she said it's. Yeah, that's why I asked you. That's why I was asking you.
Okay.
25 seconds.
Let's move on. So the slide is over here is about the nerve root injuries. Maybe due to ruptured intervertebral disc. Folks, please, at the back. Maybe due to ruptured intervertebral disc, which is one of the common injury of improper lifting of weight. Can cause sensory deficit, can cause motor weakness, sometimes pain, spinal nerve root compressions, or paresthesia and numbness, particularly of the leg and the foot. And we do have knee reflex or ankle reflexes, may be diminished, or in some cases, if it's severe, it is absent. Knee reflex, we use a hammer, put hammer on a rubber mallet on the patellar tendon to see the knee reflex, and tendo-Achilles, calcaneus tendon at the back of the ankle. We do tap on those calcaneus tendon to see ankle reflexes. Now the cerebellum, which is located posterior to the midbrain, inferior to the occipital lobe of the cerebral cortex. What it does, they said only about coordination of motor movement. Coordination of movement, muscle tone, posture, balance, equilibrium, all are done with the help of cerebellum. Muscle tone, posture, equilibrium, and coordination of motor movement. Cerebellum associated movement disorders causes may be cognitive or congenital defect, may be due to other causes, may be vascular accidents, or may be due to growing tumor. These are types, special highlight of cerebellar tremor. And also very important, cerebellum is maintain the body balance. Body balance is very important. It's one of the important functions of the cerebellum also. Now the basal ganglia, these are group of deep interrelated subcortical nuclei. These are, if you folks remember, the cerebral cortex or cerebrum, outer surface of the cerebrum, we do have gray matter. Underneath the gray matter of the cerebral hemisphere, we do have white matter. That's fourth atom, white matter. And within those white matter, we have scattered gray matter in the form of nuclei we call basal nuclei. Is it clear? Basal nuclei, these are a collection of gray matter within the white matter of the cerebrum. So, what happened in the spinal cord? What is the distribution of gray matter and white matter in the spinal cord? In the spinal cord, gray matter is outside or inside?
Outside.
Outside?
Inside. Inside.
Spinal cord. Spinal cord has gray matter within, with the letter H-shaped structure. Letter Henry is a gray matter, H-shape. And that is surrounded by white matter. That is my spinal cord. And just opposite of this one is for the cerebral hemisphere. Gray matter is outside. Underneath the gray matter, we have white matter. And within those white matter, we are right now, we're talking about the basal ganglia. Those are collections of gray matter within the white matter. And individual IQ, intelligence quotient, IQ, thicker the gray matter, smarter the person. In the human, thick layer of the gray matter is more thick, as if it is more thicker, the person IQ is higher. In monkey, difference between monkey and human brain, they have thin layer of gray matter. They have everything same, but the gray matter in the monkey brain is very thick. That's the difference in human and the brain. Okay. Now, let's talk about the basal ganglia. So basal ganglia, I said already, is a group of deep, interrelated subcortical nuclei that play an essential role in control of movement. In the textbook, page 451, there is a diagram. In the textbook, there is a diagram of the basal nuclei on page 451. Okay, so what they do, they receive indirect input from the cerebellum and from all the sensory system, not only the cerebellum. They do also receive input, sense information, my vision, and my direct input from the motor cortex. So these basal ganglia receive information from the cerebellum, from the eye, and from the motor cortex. What they are doing, they function in the organization of inherited and highly learned and rather automatic movement program. That's why we get trained. They also are involved in cognitive and perception functions. So higher the basal ganglia function, more advanced function, more smarter, more responsive the person is. Please highlight, these are the components of the basal ganglia. I'm talking about page 451 in the textbook. We have parts of the basal ganglia. I'm going from below upward. We have globus pallidus, putamen, and caudate nucleus. These are the structures of the basal ganglia. Now, if you look at globus pallidus and putamen, they together form my, if you look at the globus pallidus G and P, globus pallidus and putamen together we call lentiform nucleus. Lentiform, globus pallidus and putamen together we call lentiform nucleus. Is it clear? Now look at that one. Now putamen and chordate nucleus. Putamen and chordate PC. PC is we call corpus stratum. Corpus stratum. So that is. Now, next is the connections. There are 4 functional pathways involving the basal ganglia. Number 1, this is the one most commonly affected. Dopamine pathway from the substantia nigra to the corpus stratum, to the stratum. The next pathway is GABA, gamma amino butyric acid pathway from the stratum to the globus pallidus and the substantia nigra. Substantia nigra is the key area of the basal ganglia. Of course, we do have acetylcholine secreting neurons, which are important in the network with the new stratum. New stratum is the new corpus stratum. That's what I call new stratum. Then we do have multiple pathways, multiple general pathways from the brainstem that secretes epinephrine, neurotransmitter, serotonin, enkephalin, and several other neurotransmitters in the basal ganglia and the cerebral cortex. From whole of this paragraph, please remember dopamine. Dopamine. Is it clear? Dopamine is a neurotransmitter secreted by the cells of the basal ganglia. And that is substantia nigra. Now, if the basal ganglia are affected, what happened? Involuntary movements become affected. Alteration in the muscle tones become affected. And disturbance in body posture. All these features we do see in patients with Parkinson's syndrome or Parkinson's disease. We do see all these features are present. Please highlight, these are the involuntary movements. Highlight tremor. Write down intention tremor. Tremor which is intention tremor. Sometimes tremors occurs at rest. I'm not doing anything, but you guys notice that my hands are shaking. Sometimes I'm going to reach to some glass of water, my hands are reaching. This is also tremor, but this is tremor at rest. Now, tics, highlight, chorea, highlight, athetosis. Patient with cerebral palsy. Body movement. Patient with cerebral palsy, if you see those patients, that is athetosis. Warm, we call warm like body movement. Patient with cerebral palsy. We do have bellismus. Please highlight dystonia. And last one over here is called dyskinesias. Yes. Write down, with dyskinesia, write down tardive, T-A-R-D-I-V-E, tardive dyskinesia. Sometimes the patients are for long-standing antipsychotic drug medication, and they do suffer from the effect of those drugs. And my lips, facial expression, grimacing, tongue. These are the movement of those patients who are having those medications for a long time. We call tardive dyskinesia. She never had before. For last 2 days, I noticed that she's having that movement. Yeah. Then they take history of patient, medication history. That's the one, a medication. And they give antidote for that movement. Tardive dyskinesia. Okay. Parkinson, I already mentioned a couple of times. Parkinson disease affect my basal ganglia. It's a degenerative disorder of the basal ganglia function that result in variable combinations of tremor, rigidity. We call hands are like this. Hands are, it's very hard to make an extension of this patient hand because it's already flexed, it's tight. We call cog wheel rigidity. Cog, C-O-G, cog wheel rigidity. Bradykinesia walks. And when we walk, usually we normally walk like this. But those patients with Parkinson, their foot is rubbing on the ground. And body posture is leaning forward. That is Parkinson. So that falls under bradykinesia. Now, characteristic. Progressive destruction of the nigrostriatal pathway, which is supposed to secrete dopamine, with subsequent destruction of the striatal concentration of dopamine. Dopamine is not there. And that's why we're having all those features. Those tremor, rigidity, bradykinesia, and so forth. Condition is Parkinsonism. Please highlight and remember. Okay. A myotrophic lateral sclerosis, I mentioned earlier, is a baseball player, remember? Polyneuropathy, remember? So it's a devastating neurologic disorder that selectively affect my motor function. Prognosis is not good. After diagnosis, maximum lifespan from 2 to 5 years.
What is it?
Lifespan after diagnosis of ALS, 2 to 5 years. That means prognosis is not good. Right there. So it's a survival period 2 to 5 years from the onset of symptoms. Patient die of respiratory failure because my diaphragm, whatever muscle, is a smooth muscle or skeletal muscle? Skeletal muscle. So diaphragm is a skeletal muscle. We do need motor nerve, motor neuron. And this Lou Gehrig disease or ALS affect my motor neuron. That's what I'm having. The cause of death is respiratory failure. The diaphragm become paralyzed. Okay. Now the location of motor neuron affected by ALS, anterior horn cells, of the spinal cord, maybe the motor nuclei of the brainstem, particularly the hypoglossal nuclei. Hypoglossal nuclei give rise to what is the 12th cranial nerve called?
What, I'm sorry?
Hypoglossal. That nuclei, hypoglossal nuclei become affected, and person having difficulty in swallowing. Not only the respiratory arrest because of the diaphragm, also person is unable to swallow because my tongue become paralyzed. Tongue is a skeletal muscle. Diaphragm is a skeletal muscle. It is a type of upper motor neuron lesion. Upper motor neuron lesion. Death of lower motor neuron leads to denervation with subsequent shrinkage of the musculature and the muscle fibers atrophy. Prognosis is not good. Next. So please remember ALS. Before we mentioned about the Parkinson's disease. Okay, now MS, multiple sclerosis, is a demyelinating disease of the CNS. Now comes the story about oligodendrocytes. If you remember, we discussed that one earlier with the peripheral neuropathy. Now, most common cause is non-traumatic, caused by neurologic disability among young and middle-aged adults. 20 to 50 years age, that's the most common onset. Characterized by exacerbation, go up and down, the symptoms. Characterized by exacerbation and remission over many years in several different sites in the CNS. Initially, there is a normal or near normal neurologic functions. Patient is completely fine, no symptoms, but still MS. Some periods, symptoms become severe. As the disease progresses, there is less improvement between exacerbation and increasing neurologic dysfunction, multiple sclerosis. And that that involves MS, destroy my oligodendrocytes. Oligodendrocyte is supposed to myelinate my axons, nerve fibers in the CNS. Those oligodendrocytes are destroyed. And as a result, I'm having those symptoms of MS. Demyelination is the causative factor in which disease? Demyelination, we already said. And that is my, look at that one, oligodendrocyte. I'm going to blame oligodendrocytes. So multiple sclerosis, please highlight discussion. It is an autoimmune disease or condition that destroy my oligodendrocytes. Oligodendrocytes and Schwann cell, functionally they are same. Myelination. Oligodendrocyte in the CNS and the Schwann cell in the PNS. Okay, so spinal cord injury. How we define? It is a damage to the neural element of the spinal cord. Neural element of the spinal cord. Most common cause is road traffic accident. That is motor vehicle crashes. History of fall, violence, violence, or sporting activities. It might involve. Most spinal cord injuries involve damage to the vertebral column and or supporting ligaments as well as the spinal cord itself. Normally involve both sensory and the motor functions. Okay, the types of injuries to the vertebral column, the fractures, the dislocation, and subluxation. Ligament becomes loose. These are in the text. You guys can go ahead. Central cord syndrome, anterior cord syndrome, Brown secured syndrome. Look at the diagram in the textbook also with the cross section of the spinal cord. Conus medullary syndrome, the distal most part of the spinal cord will become damaged. And also very important is, if you look at the PowerPoint also, there is some injury that involves my cervical level that causes paralysis of both the upper limb and the lower limb. It depends on what level you're having injury. Highlight all of them. Areas affected by spinal cord injury. This is slide 1 and this slide 2. Spinal reflexes become affected. My ventilation and communication become affected. Autonomic nervous system become affected because the autonomic nervous system, the fibers of the autonomic nervous system is coming from the spinal cord. If you folks remember, the sympathetic fibers are coming from T1 to L2. That's why sympathetic system we call thoracolumbar. If you folks remember the parasympathetic, they're coming from where? What is the origin of parasympathetic? Parasympathetic. From which level of the CNS my parasympathetic fibers are coming? Or, yes. We just said my sympathetic fibers are coming from my spinal cord segment from T1 up to L2, all in between. All this segment of the spinal cord sending fiber for my sympathetic region. What about the parasympathetic? Anybody? What is the other name of parasympathetic? No? I'm hungry. I need it. What is the other name of sympathetic? Sympathetic we call thoraco. If you look at that, sympathetic is called thoracolumbar because the fibers are coming from all the T1, T2, T3, T4, T12 plus L1 and L2. That's what the sympathetic called thoracolumbar. Whereas parasympathetic is called craniosacral. Please write it down and remember. Maybe some NCLEX questions will pop up somewhere. That's pretty basic thing. Craniosacral. Cranio means cranial nerve. 3, 7, 9, and 10. Cranial nerve 3, cranial nerve 7, cranial nerve 9, and cranial nerve 10. These 4 cranial nerves send fibers for parasympathetic. And which part of the spinal cord? Sacral 2, 3, and 4. Sacral 2, 3, and 4 segment of the spinal cord send fiber for my parasympathetic system. That's what they call craniosacral. Parasympathetic. Okay. That's why it says over here, If you look at the number 3 point over here, autonomic nervous system affected. Temperature regulation, edema and deep vein thrombosis, sensory motor function. Skin integrity is lost. Pain reception is altered. Bowel and bladder functions and sexual functions. Oh, this is okay. Let's move to the next chapter is chapter 16. Okay, now we're going to deal with the brain. And also with the brain functions or disorders, please know what is the normal anatomy.
What is what, I'm sorry?
Normal anatomy for the brain. The brain is covered by meninges. We have dura matter, ecnoid matter, pia matter. There are 3 layers. And the parts of the cerebral hemisphere, right and left. And each of these hemispheres are joined in the middle. But it's what? Who hold those hemispheres together? My right cerebral hemisphere, the left cerebral hemisphere are held in position at the center within the cranial cavity by means of what? What is the name of the structure called? It's called, please write it down, called corpus callosum. Corpus callosum. C-O-R-P-U-S. Callosum, C-A-L-L-O-S-U-M. Corpus callosum. And also, folks, remember, this corpus callosum is holding to 2 hemispheres together. I'm right-handed. My left cerebral hemisphere is dominant. Is that the normal? Yes or no?
Yes.
I'm right-handed person. I use my right hand all the time, all the activities. That means my left cerebral hemisphere is dominant. That doesn't mean this is paralyzed. Right hemisphere is also working. The left cerebral hemisphere send message through the corpus callosum for the right cerebral hemisphere. With the help of corpus callosum, the 2 hemispheres are communicating with each other. Not only they're holding in corpus callosum, not holding the 2 hemispheres together in this center, but also corpus callosum is helping to communicate between the right and the left. Is it clear? That is the normal. Now, yes, and also for remember those lobes, frontal lobe, parietal lobe, occipital lobe, temporal lobe. They are functional areas of those lobes. This is very important. Blood supply is important. Blood supply for the brain is important. It is my internal carotid artery. So please remember, internal carotid artery 2 inside the brain divides into 2, anterior cerebral, posterior cerebral. Yes. So those are the normal things which is normal anatomy is important in order to dig into this chapter 16. Disorders of brain function. Now it says a common pathway common pathways of the brain damage, maybe the blood supply, effect of ischemia. Number 2, some amino acids injury. Make a note over there, we call glutamate. Amino acid by the name called glutamate.
Can you spell it?
Glutamate. Glutamate. It is in the textbook also. Okay. Now, next is cerebral edema. That's very important, cerebral edema. Whenever somebody has a head injury, that's the point is important for the neurosurgeon. And because of cerebral edema, the patient might succumb, may die. Not infection, the brain becomes swollen. So in order to cope with cerebral edema, sometimes they have to take the part of the bone temporarily. Have you seen those patients? No? Anybody? Sometimes, suppose I have edema hit on my right side, and edema is taking, they did a CT scan, they said, you're developing edema. So they take the part of the bone from the side. Temporarily, as long when the edema subsides, they put that bone back. The whole treatment is to lift the bone to reduce the pressure of the edema. That's the whole purpose. Very important. Otherwise, patient might die. Okay. Now, the last one was injury due to increased intracranial pressure. I think the normal intracranial pressure is 5 to 15 millimeter mercury. Intracranial pressure. Normal intracranial pressure is 5 to 15. We don't want to go higher than that. That might cause injury to the underlying brain tissue. Or brain damage can occur from within also because of increased intracranial pressure. And also, folks, for the normal anatomy, please remember all those spaces within the brain, ventricles. Ventricles. We have ventricles in the heart, is that correct? Right and left ventricle in the heart, atrium in the heart. In the brain, we do have ventricles, two ventricles in the two hemispheres. We call lateral ventricle. Lateral ventricle. Right lateral ventricle, left lateral ventricle. Then we do have ventricle by the name called third ventricle. Third ventricle. Then we do have ventricle by the name called fourth ventricle. Is it clear? Lateral ventricle, third ventricle, fourth ventricle. All these ventricle, when the word ends with ventricle, that means these are the site where my CSF is produced. CSF, cerebrospinal fluid, is formed by filtration of the blood plasma. CSF is nothing special. It is my blood plasma, which is filtered through those blood capillaries within the ventricle, and then they form fluid we call cerebrospinal fluid, CSF, which carries my nutrition, which carries my oxygen, and carbon dioxide, of course, for my brain tissue. CSF. All are produced in the lateral ventricle, third ventricle, fourth ventricle. Then the CSF flow through the center of the spinal cord. Center of the spinal cord, if you folks remember, the gray matter, which is letter H, I said Henry, the center of the H is, we call the central canal. And that central canal carries my CSF. And that CSF also surrounds my spinal cord, surrounds my cerebrum. Okay. Condition causing injury to the brain, tumor, trauma, stroke, very important, metabolic derangements, or degenerative conditions or disorders. Okay. Stroke, please. Very important. Now, manifestations of global brain injury throughout the brain. Alteration in the sensory and motor function. My motor function is going, my motor sensory function is going. I'm losing those functions. My level of consciousness gradually going down. And in the textbook, they have mentioned about Glasgow. Please make a note, sticky note called Glasgow Coma Scale. Glasgow Coma Scale. We assess the patient. And in the textbook, they've mentioned about that. And also, of course, I believe we do have the PowerPoint. Okay. Now, the function is, the next one is called rostral to caudal stepwise progression. Rostral means at the front to back. Rostral to caudal. From anterior to posterior, instead of for the brain, we use rostral to caudal. Rostral means the front, caudal means the back. Cauda means tail, if you folks remember. In the spinal cord, we use cauda equina. Caudal means the back. Now, as the diencephalon, which diencephalon is made up of my thalamus, hypothalamus, epithalamus, metathalamus. I'm not going over there. Plus, remember, the important part of the diencephalon is my thalamus and hypothalamus. Then the question of midbrain, pons, medullas are affected. That's why they said from rostral to caudal. Okay. Midbrain, pons, medulla forms what? Midbrain, pons, medulla forms what?
Brainstem.
Brainstem. Very good. Brainstem. Midbrain, pons, and the medulla. These three structures together form the brainstem. Then we do have additional respiratory, pupillary, eye, and movement of the eye movement reflexes, and motor signs become evident. This is all gradual process. Skull fractures may be linear, comminuted, depressed, basilar fractures. Level of consciousness, the 3-star on this, level of consciousness. All are important. In the textbook, I said they have we call it Glasgow Coma Scale on page . Okay, I will let you guys know which page we have.
472. 472.
473, yeah. Okay, thank you. So that is the level of consciousness. I'm going to the next one. Injury from excitatory amino acid. Injury to neurons caused by overstimulation of receptors by specific amino acids that act as excitatory neurotransmitter. And that one especially is important, glutamate. Causes may be due to stroke, maybe hypoglycemic injuries, or trauma to chronic degenerative disorders such as Huntington disease and Alzheimer's dementia. And also, folks, remember, for the nutrition of my neuron, we do need only glucose. Glucose is required for my neuronal cell. They don't need amino acid, they don't need fatty acid. They need only glucose. Neuronal cells need glucose for its nutrition. Of course, they need oxygen, of course, they produce carbon dioxide. For nutrition, they need glucose only. Okay. So, level of diminution in the level of consciousness is a gradual process. Some are earlier signs, and later on it progresses. Look at that one. Inattention, mild confusion, disorientation, and blunted responsiveness. After a couple of stimulus, after a couple of questions, then it says, oh yeah, that's called blunted responsiveness. With further deterioration, the person becomes markedly inattentive and variably lethargic or agitated. The person may progress to become obtunded and may respond only to vigorous or noxious stimuli. Normally, when we touch the eyebrow region with the finger, press it, normally a normal person responds. After holding with my thumb with deep pressure, after a while, the patient responds. That's how we are. Then they move the body part. Patient move after deep stimulation. That's what it says. And may respond only by vigorous or noxious stimuli, because patient is in deep coma. Medical documentation of the brain death. Please remember, causes and irreversibility of the condition, absence of brain stem reflexes, and motor responses to pain. Number 3, absence of respiration with partial pressure of carbon dioxide of 60 millimeter or more. When patient is not breathing, or maybe has some problem in the diffusion of gases, blood level of carbon dioxide goes above normal. That condition is called what? When the blood level of carbon dioxide CO2 goes above normal, it's called what?
Respiratory alcohol.
Hypercapnia.
Oh,
Please remember, hypercapnia. Stay alert. Hypercapnia. increased partial pressure of carbon dioxide in the blood above normal. That's why it says absence of respiration with PCO2 of 60 millimeter mercury or more, which is above normal. When it goes above normal, we call hypercapnia. Now, justification for use of confirmatory tests and their result, why I'm saying the patient is brain dead. Please remember, we call criteria for diagnosis of vegetative state. Patient is there, laying in bed. Number one, put a star on this slide. Criteria for diagnosis of vegetative state. Number one, absence of awareness of self and the environment. I don't know what I'm doing. Number two, inability to interact with others. Number three, absence of sustained or reproducible voluntary behavioral responses. Lack of language comprehension. He or she doesn't know what she's talking about. The sentences are all break. We say, Saturday, eat bathroom. We look at this, everything is disconnected. She said Saturday, then said lunch, then said bathroom. She don't know what she's talking about. That's what it says, lack of language comprehension. Hypothalamic and brain stem function to maintain life. Now, continue. Bowel and bladder incontinence. That's why it's so important to have those patients with head injury. First thing they do IV, start, and catheter to get urine going. So bowel and bladder incontinence. Second last is variably preserved cranial nerves and the spinal cord reflexes. Some are preserved, most of them are lost, gradually going. The condition has continued for at least a month. Then we call a vegetative state. For last 3-4 weeks, patient in the same state, we call patient in the vegetative state. Vegetative state because for last 4 weeks, patient is suffering from those conditions. Okay, highlight. Conditions called hypoxia and ischemia. We know all those things. Hypoxia, it is a privation of oxygen with maintained blood flow. Blood flow is there, but that blood doesn't carry enough oxygen. Is it clear? That is hypoxia. If you look at the ischemia, blood flow is hampered now, or interrupted, or reduced. So that will cause hypoxia, reduced blood concentration of oxygen in the blood. Might cause focal cerebral edema. Please highlight focal cerebral ischemia, not edema. Focal cerebral ischemia results from stroke. Now, global, all over the cerebrum, blood supply is hampered. Cause is my myocardial infarction, heart attack. Heart attack causes global, and the stroke itself can cause focal. Then That focal cerebral ischemia depends which part of the brain is affected. Sometimes the patient with a stroke becomes totally blind. Totally blind. Sometimes speech is gone. Sometimes the motor area is gone. That is the effect of focal effect of due to stroke. Focal cerebral ischemia. Okay. Which of the following is not common cause of neural injuries? Which one? Not cause of neural injury.
Gray.
Recreational drug. Wow. Recreational drug use can cause damage, but it is not a common cause. It's going to be a common cause right now because all are legalized. You folks understand what I mean? Marijuana, all those, cocaine, marijuana especially, all legalized. Intracranial pressure. Okay. Increased intracranial pressure is a common pathway for brain injury. And with that intracranial pressure, okay, can obstruct the cerebral blood flow. As a result, they can destroy my brain cells. As a result, they can displace my brain tissue and damage delicate brain structure. That's why we do CT scan. We do see the position of the interventricular, which do see the position of the lateral ventricle. If the in between the two lateral ventricles, we do have wall. And we do see whether the wall is displaced or not. If the wall is displaced, definitely it is due to the pressure effect. That's why we do CT scan. Cranial cavity, within the cranial cavity, we do have 10% of my blood within the cranial cavity, 80% of the cranial cavity contain the brain tissue, and 10% we contain my CSF. So, normal pressure, please highlight from 0 to 15 millimeter mercury. And there is a phenomenon we call Monroe-Kelly hypothesis of normalization of intracranial pressure. So if you look at the brain tissue, is 80%, blood is 10%, and CSF is 10%. So if one is increasing, other factors like blood and the tissue become compromised. They manage somehow to maintain, to have a normal intracranial pressure. That's called Monroe-Kelly hypothesis. One is supporting the other. Among these three players, my blood, my brain tissue, and my CSF. There are different types of herniation of the brain. Please go over cingulate, central transtentorial, ankle. Now look at those. All this herniation due to the displacement, they can cause hemiparesis. They can cause pupil to dilate. They can affect my visual field loss, or they can cause respiratory arrest. Where the respiratory center is located? Respiratory center is located where? Now, by the way, where is my vital centers is located? Vital centers. Which part of the brain has vital centers? Which parts of the brain has vital centers? Because it kicks in because with respiratory arrest, I said I need to discuss that. So where is, somebody said, we do have vital centers. Then he or she asked, where is located? Which part of the brain have vital centers?
Is it the medulla?
Very good. Medulla oblongata has my vital centers for my respiration, for my heart rate, and for my blood pressure. We call respiratory center, vasomotor center, vasomotor which regulates my blood pressure, and the cardiac centers which regulate control my heart rate. Those are vital centers are located in the medulla. Very good. Okay. Hydrocephalus. Those kids with the big head, full of water. Hydro means water, cephalus within the brain. Now, hydrocephalus, highlight, is an abnormal increase in the CSF volume in any part or all of the ventricular system. Ventricular system, I already mentioned about the ventricles, little ventricle, third ventricle, fourth ventricle. And the third ventricle, fourth ventricle are connected by cerebral aqueduct, I didn't mention, but that is not part, that is connecting the ventricle between the third and fourth, but cerebral aqueduct doesn't produce CSF. It is the lateral ventricle, two lateral ventricle, one third ventricle, and one fourth ventricle. Okay, so as a result of this obstruction, abnormal increase in the volume in any part causes enlargement of the CSF compartment occurs. Maybe communicating type and non-communicating type. Decreased absorption, communicating type, where CSF is there, but the CSF is not undergoing reabsorption or absorption. Because CSF is produced by what? CSF, what is CSF? I just mentioned CSF.
Cerebrospinal fluid.
Pardon?
Cerebrospinal fluid. Cerebrospinal fluid.
I know. How the cerebrospinal fluid is formed? Who is forming cerebrospinal fluid?
Blood plasma.
Pardon?
It's blood plasma.
Blood plasma is filtered. After filtration of the blood plasma, turned into CSF. Because within the blood, we have plasma and the blood cells. In the CSF fluid, we have the fluid, we have protein and all those chemicals, but we don't have blood cells. That's what I call filtration. Okay. And this CSF, which is produced with the help of with the filtration of the plasma, these CSF go back into the circulation, go back into the blood. Please remember, CSF is not staying there forever. After the functions are over, they're going back into my circulation. And with the help of, we do have a finger-like projection, we call arachnoid villi. If you folks remember, arachnoid villi, they cause the absorption of the CSF, throw back them into my blood. We do need a certain volume of CSF. We need a cooperation between production of the CSF and reabsorption of CSF. We do need a balance between the production and absorption of CSF. Otherwise, this thing to happen. hydrocephalus. Okay, and sometimes maybe due to non-communicating type, overproduction of CSF. Cerebral edema, highlight. There are different types. One we call vasogenic. Number two is cytotoxic. Vasogenic occurs with conditions that impair the functions of the blood-brain barrier and allow the transfer of water and protein from the vascular compartment into the interstitial space. The question is, what structure forms the blood-brain barrier? B, and B, very important. Blood-brain barrier. Can you folks name the cell which forms the blood-brain barrier? It is one of the neuroglial cells we call astrocyte. Write it down somewhere. Astrocytes. Astrocytes, along with the endothelium of the blood capillaries, endothelium and astrocyte, together they form a blood-brain barrier. Because chemicals which are okay in the other parts of the body, the same chemicals is not okay for my brain tissue. The brain needs extra protection. That's why we do have blood-brain barrier. It is the what cell? Astrocyte. Okay, next one is called cytotoxic, involves an increase in intracellular fluid. In between, the fluid is accumulated. That's called cytotoxic. Now we do have interstitial cerebral edema, edema of the cerebral white matter, as in hydrocephalus, affecting the brain. There are types of brain injuries. Please remember, one's called the primary injuries, primary/direct, and secondary. The question of over here, all those conditions are important. Contusions, hemorrhage, lacerations. Direct injury, damage is caused by a straight impact. Includes, might cause diffuse external injury or focal lesions of laceration. Please highlight, called contusion and hemorrhage. Secondary injuries, damage result from subsequent brain swelling, infection, and cerebral hypoxia. Maybe often diffuse, widespread. Please highlight the condition called concussion, infection, or hypoxic brain injury. This is, I think they have the diagram also in the textbook, types of hematoma, maybe epidural, maybe subdural, maybe intracerebral. Hematomas in various places. Hematoma, put a star on hematoma. Brain injuries can be categorized as traumatic, and that is epidural hematoma, subdural hematoma, concussion, contusion, or diffuse axonal injury. Please remember concussion, contusion. And then we do have epidural hematoma outside the dura, below the dura, and intracerebral. Non-traumatic brain injuries like stroke, infection, tumor, seizure, so forth. Okay, so please remember with the epidural hematoma, there's a diagram also, subdural. We do have focal. Focal means localized. The word focal means localized. Diffuse means widespread. Primary brain injuries include focal, like at the site of trauma, we call contusion, laceration, hemorrhage, we discussed earlier. Secondary is diffuse and may be due to cerebral edema, hypoxia, or infections. Please highlight, it says coup and counter coup. Highlight coup and the counter coup. Okay. Okay, what's next? After this couple of slides, we'll go for the break. Okay, coup and counter coup. Please highlight coup and counter coup. So brain flows freely in the CSF. And also, folks, please remember this formation of CSF within the ventricles, and how it circulates and how it goes back into the blood circulation. So the brain flows freely in the CSF. Whenever there's a blunt force to the head, accelerate the brain within the skull, and then the brain decelerates, stops slowly, abruptly, on hitting the inner skull surfaces. That's the question of coup, and the opposite side is counter coup. Coup is direct contusion of the brain at the site of external force. Counter coup, it is the rebound injury. Somebody hit me in the forehead. I got the coup. Later on, they said, no, because of the impact was so hard, your occipital lobe is also affected. The injury at the occipital lobe is counter coup because of the impact. Counter coup, rebound injury on the opposite side of the brain. Okay, so rotational is going to call
Counter coup.
Counter coup. After called post-concussion syndrome. Please highlight the term called concussion. Refers to an immediate and transient loss of consciousness. Immediate and transient. Two things over here. Or loss of what? Consciousness. And then is accompanied by brief period of amnesia and follow a blow to the head after a blow to the head.
It's like boxing when they get knocked out.
It's passed out, then they go back, come in, what happened, and then go back again. Amnesia. In all the cases, amnesia is not common in all patients. Now, recovery usually takes within 24 hours. And mild symptoms may persist for months. effect of head injury. Difficulty sleeping, insomnia, become irritable. And also sometimes the effect sense of smell also. Poor concentration and memory, the headache. Okay, so let's make a pause over here. 11:45, 12 o'clock. Returning time, 12 o'clock. Okay. Folks in Zoom, we are having a 15-minute break, returning time 12. Okay.
Professor, can you answer a question for me?
We are having break right now.
I can't get a question answered.
Question, can you repeat the question?
That's okay.
Okay. Oh. Use the restroom.
It's his long legs. I said it's your long legs. It's a compliment.
You're so nice sometimes.
Muscle legs.
Huh?
I'm so hungry. All this like brain stuff again.
You know, how much like Minesweeper? Game with the bomb. And then I get
Okay, folks, so let's expect the last round. You guys are excited for the last round?
Yes.
Okay, folks, stay focused right now. I mentioned about those hematomas in different locations, epidural, subdural, intracerebral. Now, epidural, it develops between the inner tables of my skull bone and the dura. Outside the dura, below the bone. Under the between the periosteum of the skull and the dura, that is called epidural. We do have subdural, develops. Look at the second one, subdural. It develops in areas between the dura and the arachnoid matter. That's why it's called subdura, below. Intracerebral, within the substance of the brain tissue, maybe multiple or maybe single occurs in any lobe of the brain, but are most common in the frontal. Please highlight and remember, most common in the frontal and the temporal lobe. Intracerebral hematoma, most common in the frontal lobe and the temporal lobe. Because of coup and counter coup mechanism. Blood supply, please remember the blood supply. I said know the normal blood supply by means of 2 intercalated arteries and 1 vertebral arteries, one on each side. 2 vertebral arteries join to form basilar artery. And all these vessels meet around the pituitary gland at the base of the brain. We call this circular network of blood vessels. These are called circle of Willis. Highlight circle of Willis located at the base of the brain. Okay. And also at the circle of Willis, aneurysms rupture sometimes. Small blood vessels rupture. Blood flow is controlled by autoregulation, sympathetic stimulation, and by metabolic factors, which affect the blood flow also. Carbon dioxide, oxygen, and hydrogen. Risk factors and deficit of stroke depends on age, sex, race. These are the factors all. Smoking, hypertension, these are very important. Diabetes. Some are sickle cell disorder, hyperlipidemia. What is hyperlipidemia?
Elevated cholesterol.
High cholesterol. That might be disposed to a stroke formation. Stroke. Atrial fibrillation. Stroke might cause my motor deficit, my speech, and my cognitive and other deficits. So it depends on which part of the brain, which lobe of the brain is affected by stroke. Please highlight, among stroke, there are two main causes. One is ischemic and the other one is hemorrhagic. Ischemic cause of stroke is almost 70 to 80%. And the rest belongs to hemorrhagic. So ischemic stroke is the important. Caused by interruption of blood flow in the cerebral vessels. And these are the most common type of stroke, accounting for 70 to 80%, which that's already said. And almost in the book, I think they said 13% belongs to hemorrhagic stroke. So remember, the rest belongs to hemorrhagic stroke. Maybe that hemorrhagic stroke may be the rupture of the blood vessels, maybe due to my pre-existing hypertension, maybe aneurysm, or maybe some blood malformation in the blood vessels we call arteriovenous malformation, or maybe due to traumatic injury, or some type of blood dyskinesis. These are the warning signs. Signs, symptoms of cerebral aneurysms. Aneurysms, the most small aneurysms are asymptomatic, no symptom, but still I'm living with that one. But large aneurysm may cause chronic headache, patient complains headache, or neurologic deficits, or both. Now, please. Other manifestations include signs of meningeal irritation, headache, patient complains of headache, we call neck rigidity, patient complains of vomiting. Those are all due to meningeal irritation. Cranial nerve deficits, stroke syndromes, cerebral edema, and increased intracranial pressure, and also may involve the pituitary gland. So over here, please remember meningeal irritation, signs of meningeal irritation. Patient might have a history of hypertension. Patient might have a history of irregular heartbeat, result from massive release of catecholamines triggered by subarachnoid hemorrhage. Now, aneurysmal subarachnoid hemorrhage bleeding into the subarachnoid space. Now it is located now, it's not subdural, it is subarachnoid. Causes, most common is congenital defect. Others are acute intracranial pressure, history of smoking, history of hypertension, history of alcohol, excessive alcohol intake. This is another condition called arteriovenous malformation, defect in the malformation in the arteries and veins. Which type of stroke is the result of rupture of blood vessels? Hemorrhage. Typical problem arising from stroke. Please highlight. Number one, motor deficit is the most common. Somebody has a stroke, motor deficit is the most common, followed by deficit in the language, followed by sensation, followed by cognition. So first of all, my motor functions are impaired, followed by sensory, my speech, my sensations, and cognition, and so forth. Please highlight conditions when the infections involve the meninges, we call meningitis. When it involves my brain tissue, we call encephalitis. Encephalitis is not meningitis. Encephalitis is the infection or inflammation of brain tissue. When it involves the spinal cord, we call myelitis. When it involves both brain and the spinal cord, my CNS, we call encephalomyelitis. Look at the condition. Encephalitis, it is the brain. Myelitis, the spinal cord. Combination is encephalomyelitis. Organisms might invade, maybe bacterial, viral, or others. Please highlight meningitis. What is meningitis? It is the inflammation of the pia mater, inflammation of the arachnoid mater, and the CSF-filled subarachnoid space, everything. That means, except the dura, all are involved. Pia mater, arachnoid mater, and the subarachnoid space which contains my CSF. Please highlight the patient presents with fever, chill, headache. Highlight neck stiffness, stiff neck, abdominal pain, extremity pain, pain in the limbs, and that is important. Vomiting, nausea and vomiting. Patient present with fever, vomiting, neck stiffness. Something wrong with the meninges. Maybe causes maybe acute lymphocytic, acute purulent, or caused by bacteria. Most common bacteria, please highlight, called pneumococcus and meningococcus. These are viral, these are bacteria. People living in those places like correction centers, daycares, preschool, chances of spread of meningitis are more over there. Dorm, students live in dorm. Encephalitis, infection of the parenchyma of the brain and the spinal cord, encephalomyelitis. Transmission by ingestion, mosquitoes, and rabid animals. Dog bite. We have most common is due to virus, followed by bacteria. Look at the West Nile, highlight herpes simplex virus, highlight West Nile virus, mosquito, mosquito, mosquito. West Nile virus. Brain tumors may be benign or malignant. This is the only tumor over here. Normally we say benign are good. Is that correct? Normally benign tumors has good prognosis. Malignant tumors are not. But when you're talking about the brain tumors, doesn't matter benign or malignant, prognosis is bad. Even if it is benign, prognosis is good because of the size of the tumor, location of the tumor, and the pressure of the tumor. Benign tumors are not good for the brain. And also, for the brain tumors, we do have for the brain tissue, if you look at the brain tissues are made up of two different types of cells. Neuron or nerve cell, and other is what? For this other cells for the brain tissue. One is I said the neuron or nerve cell, which is my neuron or nerve cell. The other is neuroglia. Neuroglia. If you look at the neuroglia, there are 5 different types of neuroglial cells. Oligodendrocytes, we mentioned a couple of times, oligodendrocytes for multiple sclerosis. Now, we mentioned about the astrocytes for the blood-brain barrier. We have ependymal cells. We have microglial cells. All these are my neuroglial cells. Now, the brain tumors, most of the brain tumors originate from these neuroglial cells. Is it clear? They don't involve the nerve cells or neuron. They arise from the neuroglial cells. Okay. So we do have neurons and the neuroglia. I mentioned about different types of neuroglia. So the primary intracranial tumor that originate in the skull cavity are not derived from the brain tissue itself. It is the meninges may be involved, maybe the pituitary gland may be involved, maybe the pineal gland may be involved, or primary CNS lymphoma. We have metastatic tumors, other parts have cancer that spread to my brain. And we do discuss in terms of benign versus malignant. Ependymoma, meningiomas, and primary CNS lymphomas. All these tumors causes increase in pressure effect, increase intracranial pressure. And depending on where they're located, they can cause focal disturbances in the brain function. Or they can cause edema. They can cause pressure effect on the blood vessels. Hamper circulation can cause ischemia. Or these tumor cells might infiltrate, or the tumor is capsulated, but it's causing a pressure effect on underlying brain tissue. That's called brain compression. As I said, prognosis doesn't matter benign or malignant. Prognosis is not good for benign. Or treatment. There is surgery, irradiation, chemotherapy, diagnostic, perform MRI, CT scan, and electroencephalogram, or visual field to see what is going on. Is there any pressure effect on the optic nerve or not? Include physical and neurological examination. Epilepsy is a different story. Syndromes of associated seizures type. All epilepsy, they have seizure or convulsion. So in those epilepsy, we examine the clinical finding, hereditary pattern, and sometimes they do have, in some cases, they do have precipitating factors. Please highlight the seizure. What is seizure? Is that the abnormal behavior caused by an electrical discharge from neuron in the cerebral cortex. That is my seizure. As for the convulsion, a specific seizure type of motor seizure involving the entire body. Sometimes the seizure, we do see a part of the body is moving. Convulsion is whole body is shaking. That is convulsion. seizure may be caused, but please highlight. Seizure may be caused, what is general cause, what is usual cause? Caused by alteration in cell membrane permeability or distribution of ion across the neuronal membrane. These are the usual cause of any seizure. And I'm jumping to the last one, may be caused by neurotransmitter imbalances, such as acetylcholine, GABA, and deficiency has been, these are the two neurotransmitters, imbalance of these two neurotransmitters can cause epileptic seizure. Sometimes runs in family, genetic, mutation causing ion channel defect. We do have seizures classified in the textbook also, please. We have partial seizure, grand mal seizures, under generalized seizures. There are different types: absence seizure, atonic seizure, myoclonic seizure, tonic seizures, tonic-clonic seizures. These are the different forms of generalized seizure. This is a severe form of epilepsy. And also it is very important, when somebody is having seizure, we need to take control of those patients. We're not supposed to put anything in the patient's mouth if somebody is having a seizure. We're not supposed to we can give some pillow and remove all those furniture if he or she is around the furniture. To protect the patient is important. Okay, so status epilepticus is like for asthma. We call, I mentioned that one, we call status asthmaticus, is a severe form of asthma. Over here, we're talking about severe form of epilepsy. That's called status epilepticus. Supposed to be stopped within few minutes, within few seconds, but it's not, still going on. Continual seizures. Number 2, do not stop spontaneously. If untreated or not stopped, can lead to death due to respiratory failure. Okay, I'm moving with the next, and also with the chapter 15, 16. Don't forget about the part of the respiratory system, like the pleura. Pleura, inflammation of the pleura is called what? Pruritus. Accumulation of fluid within the pleura is called what? Accumulation of fluid within the pleural space called? Pleural effusion. Maybe the serous fluid, maybe pus, maybe lymphatic fluid. That's all falls under pleural effusion. And pleural space may be affected due to spontaneous rupture of air-filled blister of the surface of the lung. We call it spontaneous pneumothorax. Please remember, we call tension pneumothorax. Spontaneous pneumothorax, tension pneumothorax. Then we discuss, if you remember, we discussed about the asthma. maybe due to allergic, causes obstruction of the bronchioles or bronchi, inflammation, causing narrowing of those tubes. And this asthma is reversible or irreversible? Can we change asthma to normal? Yes, by giving those bronchodilators come back. But the patient need to take care of what causes the asthma also.
The allergy.
Now, the condition called bronchiectasis, please remember the condition called bronchiectasis. The permanent dilation of those bronchi, the bronchioles.
Bronchial what?
Bronchiectasis. Bronchiectasis, patient presents with fever, the cough, that is long-standing, that's called bronchiectasis. I've been smoking for years and years, and now I developed emphysema. So those with the lung conditions. Occupational lung diseases are important. Occupational lung diseases. I'm working in the cotton factory, and those cotton fibers are going in my respiratory tract, causing bassinosis. Bassinosis, is it clear? And we do have overall condition of the lung, which affect condition of the lung because of my occupation. We call under the common umbrella, we call pneumoconiosis. Pneumoconiosis. Pneumoconiosis, we divide what causes, like I just mentioned about bassinosis. Sarcoidosis. Sarcoidosis is also involved my lung. What else would there? We mentioned about the blood pressure within the pulmonary circulation. We mentioned about the blood pressure within this pulmonary circulation. Where we have low blood pressure, in the systemic or in the pulmonary?
Pulmonary.
Pulmonary is almost 1/6 of the systemic. If for any reason or any cause, if the blood pressure within my pulmonary circulation increases, that causes what? Blood pressure within the pulmonary blood vessels increase, pulmonary artery blood pressure increase.
Corpopulmonary, is that?
What is that condition called? Increased blood pressure within the pulmonary arteries.
Corpopulmonary,
Corpopulmonary is affecting my heart.
Oh, sorry.
Because of the lung, my heart is paying that price. That is corpopulmonary. You're talking corpopulmonary. It's called pulmonary hypertension. Pulmonary hypertension. Okay. What else? So please take care of those portions from the respiratory system also, along with the nervous system. We discussed a lot of things today. Okay. Let's take care of the last part. As I promised, I said I'm going to discuss. I got that from Dr. Dev. This is in connection with the nervous system. The pretty basic thing is all refreshing anatomy first. Look at those things. And all are important. Number one, neuron. What is neuron? It is the basic functional units of the nervous system. Neurotransmitter, we know neurotransmitters. We discussed so many different acetylcholine, norepinephrine, serotonin, Dopamine. Dopamine we discussed with Parkinson's disease. Acetylcholine we discussed with myasthenia gravis. Feel good hormone, serotonin. Central nervous system. First of all, the nervous system. Nervous system is divided into two components: central nervous system and the peripheral nervous system. For the central nervous system, we have the brain and the spinal cord, nothing else, don't add anything. And the peripheral nervous system has what? What is peripheral nervous system made up of? Peripheral nervous system, you respond.
Cranial nerve, spinal nerve.
Yes. So cranial nerve and 12 pairs of cranial nerve, 31 pairs spinal nerve. Now, this peripheral nervous system, look at that one. Those cranial nerve and the spinal nerve, they form somatic one. On the one side, they form somatic nervous system. On the other hand, they form the autonomic nervous system. Somatic nerve or somatic nervous system, where the motor fibers form my skeletal muscles. Somatic, soma means the body. All motor fibers for my skeletal muscles only form somatic. Now, the other part, the autonomic nervous system, send message from the CNS to my smooth muscles, cardiac muscles, and gland. If you folks remember, I mentioned about the gland. Smooth muscles, cardiac muscles, and gland, they become part of my autonomic nervous system. So somatic is 100% voluntary, autonomic is 100% involuntary. Please remember. Yes? Can I move? Okay. Now, this is pretty discussed. Cerebrum divided into two hemispheres, right and left. Left, that's what I said, depends on the dominance. If I'm right-handed, my left is dominant. If I'm left-handed, right is dominant. That's what they're saying over here. Left control the right, right control the left. Now, and also I mentioned about the corpus callosum. Corpus callosum, don't ignore corpus callosum. It connects the two hemispheres together. Now, each hemisphere contains the lobes, frontal lobe, temporal lobe, parietal lobe, and occipital lobe. Just refresh all those things. I'm going back. Occipital lobe is for vision and eye reflexes. Parietal lobe, general body senses, general body sensations in terms of size, shape, weight, and texture. Temporal lobe, we do have auditory, main hearing area or auditory area. And then we do have Wernicke's area. What is Wernicke's area?
Language comprehension.
Sensory speech area called Wernicke's. Now we do have the frontal lobe, high level of cognitive functions, memory, voluntary eye movements, speech. That is motor speech area is called the Broca's area. Okay. Blood supply. Please remember, per minute, heart pump out how much blood?
5 liters.
5 liters. Out of that 5 liters, brain is getting almost 750 ml. Look at it. Brain forms only 2% of the body weight. 2% body weight in my brain, but it's getting almost 15 to 20% of the cardiac output. Now, we do have blood-brain barrier. I mentioned that one. And these are highly selective barrier. Molecules, in order to cross the blood-brain barrier, molecules must enter by active transport, by endocytosis, by exocytosis. So this blood-brain barrier is very permeable to the oxygen, carbon dioxide, and glucose. Remember I said glucose, only glucose we need for the neuron. So brain can use a brain can only use glucose for its energy supply. Look at that one in bracket. Lack of glucose for 5 minutes result in irreversible brain damage. Irreversible. That's why after having some sugary drinks or food, we feel energy. Energy means nutrition to the brain. Okay, and this is the blood supply. Please remember. Subclavian artery, look at the subclavian artery giving rise to my vertebral arteries. Vertebral arteries merge together to form basilar artery, and do have internal carotid artery also. Okay. So this is peripheral nervous system, 31 pairs and 12 pairs. 31 pairs spinal, 12 pairs cranial. Now the autonomic nervous system has sympathetic nervous system and the parasympathetic. And in the diagram, if you look at the diagram, they're showing if my C4 level of the spinal cord segment injured, my upper limb, my lower limb, my trunk, all gone, cortex spinal tract. Same thing at C6 level, cervical 6 segment of the spinal cord will also result in quadriplegia, 4 limbs. At below T6, thoracic 6, paraplegia. At L1 injury, they're also going to cause paraplegia. If you at least remember these things, it is going to help. Okay. Sympathetic and parasympathetic. The difference between sympathetic and parasympathetic. Look at the chains of ganglia. For the sympathetic, they have chains of ganglia, one on each side of the spinal cord. There's not only one chain, there are 2 chains, one on each side. And for the parasympathetic, there's no chains of ganglia. And that ganglia is called what? For the parasympathetic? For the parasympathetic, the ganglia is called what? That's called terminal ganglia. Terminal ganglia for the parasympathetic. Please go with the diagram. It says pretty clearly what's going on. What if sympathetic happened? What happened with parasympathetic stimulates? Normally, parasympathetic causes increased contraction and increased secretion. Normally. Sympathetic decreased contraction and decreased secretion. Parasympathetic slow down my heart, and sympathetic increase my heart rate. When I'm stressed, sympathetic. When I'm relaxed, parasympathetic. Okay, and These are age-related changes, decrease in mental functions with age, suffer from depression, with decreased mental stimulation, loneliness, loss of employment, loss of family, loss of friends. All these are factors for decreased mental function or depression. Motor responses or reflexes slow, decreased visual acuity, and that because of this visual acuity, chances of fall increases with age. Delirium, more common as seen of infection than temperatures. Delirium patient all of a sudden burst. These are the terms: agnosia, aphasia, apraxia. Please remember all those terms which are important. Okay. And that is level of consciousness at the end. Patient is alert, lethargic, obtunded, stupor, and coma. Okay. This is from the